let me ask you a question. You've been doing it for 20 years, right? If you were to review the last 20 years of your being exposed to different clients and patients and on the street, what was kind of your evolution? How did you progress in your learning curve?
I progressed through my patients, actually.
So you learn,
my clients.
Just like project managers learn from every project if they're not formally trained, right? It's kind of this autodidactic thing. Yeah. So you had a basis of medical understanding, but it was kind of learning by doing?
Yeah, learning by doing and learning by feedback.
Very, very important. For learning and feedback from your clients.
Yeah.
I guess seeing them on a reoccurring basis helped too?
Yeah, of course. But it was also the good feedback, actually, when you just go there and they just, they want to give you something back because they're so grateful for the help. And then first I had problems to accept these little gifts. It was some flowers from the
or coffee
park or whatever.
A cup of coffee or something.
They want to
show their appreciation.
Yeah, and then maybe this was a good job. And on the other hand, sometimes they did not come back, and so maybe I should have done better. I could have done better.
How did you, now since Lucy Bus is not just you as a person, Lucy Bus is an initiative where...
From the Caritas.
Yeah, from Caritas, with a Catholic organization that does charitable work.
Yeah.
It's not the only organization. There's also
we do
Amber Med and a number of other different organizations. And I want to mention this offhandedly because I think almost every city that we've ever reviewed.
And that's the point why we founded Med for Hope, actually.
You're going to get ahead. We want to do this step by step. We need to give the listeners enough leadway to kind of lead into the story. So you did this for 20 years. You were not the only one that did this. So there was a bunch of different doctors. Did the doctors in Louise Bush do knowledge sharing?
Yeah, of course. We met and we talked over some special problems, but it was not, it was just let's meet once in a while.
So it's informal?
Yeah, it was.
Did it change? And I'm going to use a fancy word. Did it change something in the system itself?
No.
It didn't.
No.
So the quality of your group was still very much based on individuals.
Yes.
But individuals still chose to do it any which way.
Yes.
Okay.
And I think that's a real general problem because I work for several. I also work for the Diakonie for another place. And, if you go there, they tell you, okay, the antibiotics is there, the prescription papers are here, and the stamp is there, and here you got the tests and whatever you need. But that's the way how you get instructed. It's not very
So you're talking about a universal issue that you will find in almost any discipline, and that is the issue. What are we trying to do? How do we do it? Is there a uniform common practice which is based on experience and not just on how motivated an individual is, how capable an individual is, how empathetic an individual is, or how many years of experience? Because there was probably a huge difference between somebody who's been doing it for 20 years and somebody who's been just doing it for 2 years, right?
Yeah, of course.
Okay. So,
but as you mentioned emergency medicine, I think this is really an excellent example for really, we have guidelines there, and you have to have these guidelines, for example, in reanimation. Every child all over the world knows how to do reanimation, normally, like very,
CPR.
CPR.
Yeah.
And the doctors know how to do advanced CPR.
Yeah, how do you do it if you're doing CPR on, for example, who's just had a trauma to the chest from a car accident?
You have to exact how much of what do you have to give in what situation.
So CPR, let's use this as an example. CPR is something that's pretty straightforward. If you have to do it to somebody who falls over in a restaurant, that's the context, right? The environment that you're doing it. But if you're talking about, for example, coming to a car accident, you have other conditions which have a vital role on whether or not you can do compression on the chest, or how you do the breathing aspect.
But emergency medicine did really a great job.
So let's use this. Use this as an example, because I remember when, and I'm also a member of Med for Hope, and I try to support it where I can. One of the conversations we had at the very beginning of Med for Hope was with a friend of your parents, who's a medical doctor. Remember, who was implemental. She was one of the founding members of the Association for Emergency Medicine, right? Professor Fitzal. And we tried to get her lessons learned and her experience. And she had exactly the same issue. She said, you know what? We were all medical practitioners, but we realized that the thing that we were trying to do required specialization, and that specialization was not available. So what your 20 years of street medicine taught you is all over the world, not just in Vienna, and all over Austria, all over Europe, all over the United States, there's institutions where there's volunteer medical practitioners who trying to do a good job. But one of the things that they're handicapped by is by the fact that, is there a shared knowledge base? Is there lessons learned?
It is not.
Are they including, or is everybody just doing it by the seat of their pants as best they can, which is valuable, but maybe not as effective or as efficient as possible?
I think the mistake is that in street medicine, we're now in a time when we think that it's enough to be a doctor and enough to be a general practitioner.
And enough to have a bleeding heart.
To be engaged. But that's not true anymore.